Hello and welcome to HealthWatch. I'm Dr. Vince Glielmi. On behalf of the physicians and staff at Ephrata Community Hospital, I'd like to welcome you to this segment. Today we're going to be talking about the evaluation and management of sports-related injuries. We'll be right back after this message. And welcome back to HealthWatch. We're going to be talking about sports-related injuries today, and as our guest we have Dr. Joy Long, who's an orthopedic specialist, but also a specialist in sports medicine and shoulder injuries. And welcome to our show. Joy, you've been on before, and it's always an interesting topic. I think so much about, certainly with television and the Olympics and everybody watching, we're much aware of the terminology and some of the things that are happening to our athletes acutely. And I think it probably is a good time to step back and let the public know, what are some of the terminologies that we use, and then even some of the injuries that are occurring, because we're also, with our kids playing sports repetitively, it's becoming more of an issue. So I thought let's just start with some basic terminologies. We hear the terminology sprain and strains and muscle pulls and those types of things. Kind of go through the litany, if you would, for me.
Sure. Well, the medical term for a sprain is basically an injury to a ligament, and it implies either a stretching, a partial, or a full tear of that ligament. A ligament is a structure that connects two bones together at a joint. So usually these are joint injuries. So officially an ACL tear is an ACL sprain of the knee, and there are multiple ligaments around all of the joints, and anytime you injure one of those ligaments, officially it's called a sprain.
Yeah, it's kind of interesting because I've heard even this weekend talk about sports, they talk about knee, and they talk, it may be just a sprain, but that in fact could be a tear of an ACL or something else.
Right. We grade them 1, 2, and 3, 1 being a stretch, 2 being a partial tear, and 3 being a complete rupture. So for most people, if there's a complete tear, they use the word tear, but officially it would be still a sprain.
Okay, good.
Whereas strain does imply a muscular injury. So as opposed to necessarily right at a joint, this might be away from the joint. So a hamstring pull would really be a strain of the muscle. And that can happen anywhere along the muscle, anywhere from where it starts to in the middle of the muscle, or where it ends right on a bone.
Can it completely tear?
It can, and it's pretty much the same grading system. So 1 would be like a stretch, 2 would be a partial tear, and then 3 would be a complete tear. The good thing with muscle strains is oftentimes, even if it's a complete tear, because the muscle fibers are so bulky, they will usually heal without surgery, whereas complete tears of ligaments, some of them do end up needing surgery.
Yeah, we talk about, of course, fractures are fractures. I mean,
right.
So many times there is other injuries, I guess, associated with that. We think of ankle fractures.
Right. So an ankle fracture could be something that's truly just a fracture where the bone itself breaks kind of in the middle of the bone, or it could be more of what's called an avulsion, where the ligament pulls off a small piece of bone. Those are usually treated more like a sprain, whereas the ones that are higher up in the bone may be treated a little bit more with a cast or even surgery. Yeah,
I've always heard the terminology, and there is some implication between like ankle sprains when they talk about high and low ankle sprains. And just for clarity, how are they distinguished?
So there's 3 main areas where there are ligaments around the ankle: on the outside of the ankle, the inside of the ankle, and then between the 2 bones of the ankle. And if the injury occurs between the 2 bones in the ligament called the syndesmosis, that's called a high ankle sprain, and those do take a lot longer to heal. If that is completely disrupted, if there's a grade 3 injury of that actually also sometimes does need surgery.
To surgery. Yeah, we're going to be talking about therapy as we get through this, but kind of those terminologies that we hear. Of course, the Achilles rupture, we always think of tendon ruptures,
right.
And that's probably the more common, the one we see, and classically we've seen this in Howard and all that.
Yeah, Ryan Howard was a good example recently.
Yeah, went right to ground.
But when the tendon pulls off, sometimes it tears right in the middle of the tendon, sometimes it pulls directly off the bone. Either way, when it's completely disrupted, it's no longer functional. So. Yeah,
I have to relate my own experience. Had a partial tear, kind of occurred over time, and it didn't rupture. But again, your rating system, I'm assuming that's the same thing.
Same thing, strain.
Right. So now we're going to talk about these various injuries that we look at, but kind of walking our way through as we look at the more common areas that have problems. And I know you're a specialist in shoulder injuries, so let's start there particularly.
Sure.
What kind of sports are you seeing the shoulder injuries acutely, and then some of the chronic stuff that we're seeing?
So a lot of times, if you're talking about acute injuries to the shoulder, one of the most glaring ones is a shoulder dislocation, and that we see football, lacrosse, wrestling, rugby, a lot of the real high contact sports. You can see it certainly in other sports, like someone's diving in baseball or something like that, but usually a shoulder dislocation is relatively high energy and usually a pretty big trauma. So that would be one.
And just to get back, when you talk about a dislocation, I mean, it's kind of the articulation
Yep.
of the shoulder joint.
Right, so if you think about the shoulder as a ball and socket joint, when the ball comes out of the socket, and sometimes it goes right back in, other times it has to be put back in either by an athletic trainer on the sideline, in the emergency room. So after a shoulder dislocation, most of the time people are placed in a sling. It depends on what other structures are damaged inside the shoulder, as far as is there cartilage tearing, did any ligaments tear. In a young person, like you might think of as a high school athlete, it would be unlikely to think that the rotator cuff would tear, although it's actually pretty common over the age of 40 with a shoulder dislocation, then rotator cuff can tear with that. So
yeah, is that just because of the rigidity of this as we get older? Or?
Yeah, we think so.
Yeah,
it's more likely to tear. So a lot of times people who have a shoulder dislocation, initially oftentimes they're seen in an emergency room to have the shoulder reduced or put back in place. X-rays will usually be obtained then, and oftentimes then they'll follow up with an orthopedist within a few days. A lot of times we do get an MRI to look for other damage inside the joint.
Yeah. Does it usually come forward or anterior?
So yes, so an anterior or forward dislocation is definitely the most common, and that usually happens with the shoulder up and out. So
right, and yeah, and I know that in emergency rooms in general can really, I'll use the term, pop those back in fairly easily. They give you some.
They usually go back
some
in.
medication just to kind of put you out for a little bit, and then they could pick them in. But it's where are the chronic issues that may be associated with it?
Right. So anytime you have an acute injury, it can potentially become a chronic injury or can become recurrent. Shoulder dislocations are a pretty common example of that. Or a person has their first dislocation, they may do some rehab, some physical therapy, get their strength back, get their range of motion back, and be doing okay, get back to their sport, but they're definitely at a much higher risk of having that shoulder come out of joint again. I think it varies based on the type of sport, and again on what was seen on the MRI. If there are any small fractures, or if how much cartilage damage is present. Sometimes people end up having surgery after a first dislocation. A lot of times after the first dislocation, we'll kind of we'll see if the patient is going to have continued dislocations or not. After a second, third, or fourth dislocation, at that point more and more damage is being done to the joint. And then usually the shoulder needs to be
I always
stabilized.
remember I played ball with a guy when I was younger. I hadn't really thought about it until just now, but he would dislocate us. We would be playing basketball. He would go out and he knew how to put it back in himself. And I could just imagine where he is now today. Yeah. It must have had that surgery done because must have been that loose.
Yeah, that can be very difficult for people, especially if it gets to the point where it's coming out even if they roll over in bed at night.
Yeah. All right, we're going to take a break and work our way down to some of the other joints that can sustain injuries. And we'll be right back after this message. And welcome back to HealthWatch. We've been talking to Dr. Long about sports-related injuries, and we're kind of working our way down from the shoulder. But just to mention the hip, because we were talking about this before, and there's not a lot of dislocations and stuff that occur with hips, as you see. But you can fracture your hip, and there may be sequelae associated with that. So just
Absolutely.
if you wouldn't pass it.
I would say probably the hip is one of the least commonly injured joints, which is a good thing. If a fracture occurs around the hip, it's likely that there was a stress fracture there beforehand, and those can be very dangerous because it can interrupt the blood supply to the femoral head, which is the ball part of the hip, and that can lead to a lot of problems down the road. But thankfully, that's very rare.
Yeah, kind of a rare phenomenon. We were kind of come up with a name, but we know the famous football player Bo Jackson, who in fact had that happen and ruined his career or ended his career. Let's go from the hip now and talk about the more common, probably the most common injury that can occur, and is the knee injuries, which we've all had to some extent. So, talk to me about what happens to the knee and why it happens a little bit.
Well, I think part of the problem is that the knee is a point of both rotation and flexion. So the knee does a little bit of rotation, and when you pivot on your leg, a lot of the stress goes through the knee, and if the force is just not quite right, it can tear a ligament or a meniscus, which is the cartilage inside the knee. And these can be pretty difficult injuries to recover from, especially in season. Sometimes the medial collateral ligament, which is the ligament on the inside of the knee, actually is much more likely to heal itself. So a small sprain of that is not as bad as if you were to have a tear of the ACL or a tear in the cartilage within the knee joint itself. Certainly there's all sorts of chronic problems that can happen to knees as well, just because a lot of the stress from running goes across the knee. So you may see tendinitis, which is inflammation in the tendons around the knee joint. Most of that happens either in the hamstrings, in the back of the knee, or in the patellar tendon or quadriceps tendon, which are the two in the front of the knee attached to the kneecap. A lot of times the more chronic problems can be treated with what we call relative rest. So it doesn't necessarily mean that the person has to completely stop all activity, but they may need to stop certain types of activity, such as the jumping or the sprinting part, and do cross training while they're recovering from the injury, and then hopefully get them back as they do some physical therapy. The basic rule of thumb as you're evaluating a patient is you want to see, the first thing we want to do is any swelling that's present, we'd like to get rid of the swelling because swelling limits motion. And then we want to restore any range of motion that isn't there. So if the patient has become stiff, you want to get them flexible again. And after that, you want to work on their strength and then their agility as well. You want to make sure that they can function in their sport so that they can actually protect themselves. If you're sending them back and they're still limping, it's likely that they're going to have a re-injury. So when we're doing the rehab after, say, an MCL, a medial collateral ligament sprain, we want to make sure that they're able to sprint and cut and jump and pivot and do all of those things before we send them back into the game.
Yeah, let's talk about the acute evaluation. I've always, and I've heard other, and probably yourself as well, is kind of knowing what happened at the time. We were relating to the recent Eagles injury to the center, where we've had 18 different views of how this happened, but you could actually see the person planting and then hitting him from the side. So you get a sense of what happened to the knee at the time. Does that help you evaluate these things?
Right. So yeah, when a physician is on the sideline and sees the injury occur or has a really good description from the patient of exactly how the injury occurred, it makes it a lot easier to guess which structures are going to be injured and focus your exam to that area. Especially once a patient is showing up in the office a few days later, they're swollen, they're stiff, they're kind of sore everywhere. It can be very helpful to know the mechanism of injury, how it happened. So for example, when we see a pivoting injury to the knee, we're going to worry about the meniscus, we're going to worry about the ACL. When we see the knee buckle awkwardly, then we're going to worry more about or in addition about the ligaments on the sides, the collateral ligaments. So it can be very helpful.
Yeah, that description, and then again, with the sports on television now, you can actually see the injury, but in your case, some of the football, high school games and all like that, you're actually on the sidelines.
Occasionally.
Yeah, okay. But when we see people, certain trainers are running out at the time, what can you tell in acutely as relates to the stability of the knee if you're able to examine it at the time or get a description of what the stability is? Because I see them testing them all the time, and I wondered what kind of information they can get from that exam.
Right. It's actually almost easier to examine the stability of a knee right after the injury happens because it hasn't had a chance to get swollen yet. So they're testing the ACL, also the PCL, which is the posterior cruciate ligament, and then both of those collateral ligaments, the medial and the lateral collateral ligaments, to feel as they move the joint, if the ligament is stopping that motion. If there's laxity or motion in the joint where there shouldn't be, then that's a sign of instability, and that's usually a sign that that player probably shouldn't return to the game that day.
Okay, and so you can tell that acutely on the side. And trainers, I imagine, although the pros probably have physicians at the time.
As athletic trainers are totally able to
make that evaluation.
Yeah.
So talk to me about the acute evaluation of these. You can't hardly do anything now without getting an MRI. How good is the MRI now in showing these tears?
The MRI is very sensitive in picking up injuries in the knee. Knee MRIs are almost essential these days in your young athlete because there's always pressure to get back as soon as possible. So you want to know exactly what structures are damaged and whether or not it's safe to send that person back early, or whether you really need to let them heal, or whether they're actually going to need a surgery to, say, repair a meniscus or reconstruct an ACL.
Yeah, I mean, at the sports screeners now, they have MRIs or at least CAT scans in the receiving room, so that it's really right there, and importance of knowing right away whether there is significant injury. So, but the knee injuries are just, can be career-ending, and it's so important to make those evaluations early. So we're going to take a break, but I want to come back and we'll start. We'll talk about the ankles, because again, if I had to take one thing, I've had them all, but I've had those too. So ankles injuries are very common and things that you see. So we'll be right back after this message. And welcome back to HealthWatch. We talked to Dr. Joy Long about sports-related injuries and kind of working our way down. We talked about the knee injuries, and the one thing we didn't mention was, I guess, and I've seen this happen where you get a acute patellar and all of a sudden the patella is not attached.
Right.
That
Dislocated.
kind of occurs.
Yeah, you can dislocate your kneecap. That's another one of those that can become a chronic problem. Usually the first time it happens, we'll treat it with brace and limited range of motion so that the ligaments can heal, but it can become chronic, and that can sometimes be treated just with bracing, but sometimes it does end up going on to surgery.
To surgery to really
stabilize
it. Yeah, it makes some sense. Well, we talk about knee injuries, but probably all of us have had it some time just walking off a curb somewhere. We've had ankle sprains and strains, but certainly in sports, it's not an uncommon. And we've already talked about the high and low ankle sprains, but let's go into it a little bit more about these injuries that can occur in the ankles. Can you tell by what happened at the time? Is it the same type of thing as the knee injury? What were you doing when this happened, type of thing?
Well, I do always ask my patients if they feel like their ankle turned what I call in or out, because that also helps to determine whether the structures on the inside of the ankle would be damaged or the outside of the ankle. But the vast majority are what we call an inversion sprain. And what you really have to differentiate is it a sprain? Is it an injury to the ligaments? Or is it a fracture? If you're on the sidelines, sometimes that can be a little difficult. Just palpating right on the bone, if there's no tenderness right on the bone, then usually it's not a fracture. And a lot of times with a relatively minor sprain, by taping the patient up and making sure that they can go back to cutting and pivoting, they can get back in for the game. But afterwards, it's important, the concept of RICE, rest, ice, compression, and elevation, to help keep the swelling down. Again, swelling decreases range of motion, and range of motion is something you don't want to lose. So an ankle sprain, because there's such a huge spectrum in the damage that can occur, as far as just a minor sprain to a complete rupture of the ligaments, it can be hard to predict exactly how long a patient will take to recover, but most patients get better in a few weeks. Oftentimes they'll work with either their athletic trainer if they're in a high school situation, or potentially a physical therapist, or just do some exercises on their own at home to regain their strength. And a lot of people will wear a brace for a period of time afterwards to give themselves a little bit of external stability after the sprain.
Do you ever cast them?
Occasionally, especially if there's an associated small fracture and there's a lot of swelling, but usually not, because I want them to start moving. I don't want them to get too stiff.
Sure, right. So, and you talked about the initial treatment. Most of us are kind of aware of, you kind of know when you did it. They're putting ice on it. I mean, just if you can keep the swelling down, it really helps.
Absolutely. It makes a big difference for someone who thought about putting a big bag of ice on their ankle for the first day or so after the injury before they get evaluated, versus someone who didn't have that foresight. So
yeah, it's just amazing to me too. You see these athletes, I mean, multi-million-dollar athletes, and you watch what happened to them, because of course they have 18 cameras on them. You see them going over and my God, that he must have tore everything he had. And the next thing you know, they've had him taped up and he's back in playing again. And it always strikes me as how do they do that? But
well, there's a lot of mobility in the ankle joint, so it does take a lot to tear the ligaments. So at least that's a good thing.
Yeah.
But the ankle sprains, they can become chronic as well. And I've had patients who've had so many ankle sprains that they can just turn their ankle simply walking down a level road. And ultimately, if the instability gets to that point where they can't overcome it by strengthening on their own with physical therapy or a brace, there are surgeries to tighten the ligaments of the ankle so that stops happening.
we hear the terminology stress fractures a lot in sports, and kind of where does that occur, and why is that important?
So stress fractures are most common in the lower extremities because usually it's from running and jumping. The feet are a pretty common place to get it, sometimes in the shin as well, and sometimes they can be confused with shin splints, which can be a way that they get delayed as far as the diagnosis. Basically, a stress fracture occurs when the bone is seeing too much stress to be able to recover. So your bone, just like your skin, turns over. You make more bone and take away old bone every day. And if you're taking away more than you're putting back, ultimately this tiny little crack can develop, which can cause pain, and it can complete into a full fracture if you're continuing to put repetitive stress on it. A lot of times that can be related to low calcium intake. Sometimes it's just related to a big change in training. So like, for example, someone who decides that they're going to go out for the cross-country team, but they've never really run before. So now they go from, not doing a whole lot as far as weight-bearing exercise, and now they're running miles upon miles a day. That's a setup for a stress fracture, even if they have normal calcium. Women are actually more likely to get stress fractures. It has to do with estrogen levels and menstrual cycles. People with eating disorders are also more likely to get stress fractures.
Interesting. Yeah, these are the ones that are out there running, there's a body habitus type of thing. Yeah.
Body image issues.
But yeah, I mean, it always amazes me, some of these pro athletes that they suddenly are out for the year because they've developed stress fractures, particularly in the feet. I imagine that's a major weight-bearing organ.
Right, it's hard, especially if it's gotten to the point where the symptoms are occurring even just with walking. Then patients do sometimes end up in a cast or a special boot, and sometimes even on crutches, depending on the location of the fracture. And if the fracture can't heal, if it won't heal with immobilization, then occasionally surgery is even necessary to try to get it to heal.
Right. Let's you happen to strike a chord when you talked about women and stress fractures, and it does bring up the issue, things I think you and I have talked about before on the show, but particularly the difference now in these kinds of injuries that may occur male versus female, and it's a phenomena of the last several generations now. Women are so much more involved. Let's look at the Olympics in sports, but even our own kids now that they're all playing soccer, field hockey. Women's sports in general has increased, so that's put some stresses on our teenagers, and just to relate that, what kind of injuries again are you seeing acutely women, particularly as it relates to men?
Well, the big one is the ACL. The ACL is much more commonly torn in females than males, and it has to do partially with the structure of the lower extremities, but it also has to do with muscle balance, which women are much more commonly not as good at obtaining as men. So strength training still isn't emphasized as much to our female athletes as it is to our male athletes, and especially as the young athletes go through their growth spurts and their center of gravity changes and their balance is off. If their strength between their quadriceps and their hamstrings, the two major muscle groups in the leg, is not there, then they're also at risk for big knee injuries.
Yeah, is it really just their structure as well? I mean, just the way women are different than men. Let's face it. And
hips are wider, and that puts more stress on the knees. Absolutely.
Yeah.
So.
Yeah, but like I say, you're seeing women now doing some contact sports. I mean, lacrosse and stuff that you wouldn't have thought of in the past.
Even football.
Yes, kickers.
Mostly.
Yeah, mostly kickers. So when you talk about some of these injuries that you're talking about, when you talk about acutely repairing them, for example, an ACL tear, how do you approach that when you really identify that? You had the injury, you had an ACL, this is torn. We have so many more modalities now, particularly imaging, that you know exactly what you're dealing with. How can this be done arthroscopically? How do you approach them?
The ACL reconstruction is an arthroscopic assisted procedure, so it's mostly done with the scope. So the incisions are pretty small. Usually the surgery is done within a few weeks after the injury to allow the patient to have less swelling and get their range of motion back before they go to the operating room. Makes the rehab afterwards a lot easier. And then the surgery itself is day surgery. You come in that day and go home the same day. You're on crutches, usually for a couple of weeks. And most people start physical therapy within 1 to 2 days after surgery to start working on their range of motion and their strength. full recovery can be up to 6 to 8 months depending on the type of injury that occurred and the type of graft that's used.
Yeah, we know ACL tears for professional athletes, it's not the kiss of death like it used to be.
No, but it's a season ender.
Yes, but and the one other thing, just before we leave, is that getting back to our youth is talking about if you're having if you had an injury and you're still having symptoms,
Right.
make sure you get to see your doctor, because it should resolve.
Absolutely. I like to say if something is nagging you for more than 2 weeks, it should be evaluated.
No. Well, we'll have to leave on that note, but Joy, it's always been a pleasure having you here. Thank you for coming, and thank you for watching HealthWatch.